everybody. Let's go ahead and get started. Thank you for being at our faculty development series. This is our third in the series with Dr. Stulberg leading it. Thank you, Dr. Stulberg, for being here with us. Today's session is going to be on teaching to adult learners and precepting tips. So throughout the session, Dr. Stulberg will give us guided time for question and answers. If you want to save your questions until those times, that would be great. And all right, I'll hand it off to you, Dr. Stulberg.
Thank you so much. Appreciate everybody joining us today. I'm just making one little adjustment to a slide that seemed to be hidden. And let me go ahead and share my screen now. Okay, are folks able to see the, great, let's go. So we're going to talk about faculty development 102, and we did 101 previously. Thank you to all of the New Mexico Primary Care Training Consortium staff. And this is the overview about the consortium. I'm going to go quickly through that because I think most of you are familiar with this. So today we're going to talk about adult learning theory, and also talk about some of the adult learning styles, how you can pay attention to those in your teaching, and then talk about some precepting techniques to help you be successful. So it was kind of fun when I was looking at this. At the university, we use the term pedagogy in terms of the teaching process and being scholarly and academic about things. And it was kind of fun that a couple people, one back in the 19th century, and then another person popularized it again about 100 years later, making a difference between andragogy and pedagogy. So they say, pedagogy refers back to, like pediatrics, it's like teaching kids, but adults are different. So they've actually been using the term andragogy instead of pedagogy, but at the university, it's all pedagogy. So it was just kind of a fun thing to just consider the differences on those. So the nice thing about adult learning is all of you who are joining us today, you don't have to be here. You're here because you want to be here, because you want to learn. You're typically self-directed about what you want to learn, what you are hoping to get out of the opportunities, and therefore you're dedicated your time, you're invested in this, so that can be very helpful. And the other thing that's nice about adults is they bring a substantial knowledge base to the table. They've got lots of experiences that they've had, and they can share, and you can their experiences, and you can build on their experiences too. So adult learners tend to want very practical information. They want it now, and they want to be able to put it into effect right away. They also like experiential learning, that hands-on learning, as opposed to studying about it. They want to actually do it. And they tend to seek out trusted mentors who they have either are aware of, know the reputation of that person, so that they say, you know what, I want to learn from this person because I respect this person. So I want to be able to see how they're doing things. And that can be very helpful, as opposed to an unknown entity. In terms of the common learning styles, usually it's talked about visual and auditory. Some people are more of the reading, writing learners, and then there's the kinesthetic learners. But in essence, we all bring aspects of these things to bear, and we adjust them based on the situation and what comes to mind. Often, many of us do have a preference for certain styles, and it's good to be aware of your own style. And it's also good to be aware of your learner's style also. Had a lot of fun because there was one of the residents, I was looking at him, he could tell I was thinking, he says, what are you thinking? It's like, I'm trying to figure out the best way to help you learn, because he was a nurse practitioner who was in a residency program. He had a wealth of skills and experiences already, and he really needed a little bit of a different approach rather than people who were just starting out in medicine. So the folks who are visual learners, they like to put things together visually, and then that layers into their mental map. I say a lot of people, we have like a filing cabinet of information or a structure, and then we start to build on that structure, and we start to pigeonhole things, and in our minds we put those things together. So the people who are visual learners, they like to put things together with diagrams, step 1 to step 2, that visual process as they go along, and that helps them to make those linkages and process the information. Flowcharts can be very helpful for those individuals. People who are auditory, these would be great people for podcasts. They just absorb the stuff auditory, so they can do it while they're driving. They don't necessarily have to have that visual linkage. They can hear things, and in their mind later, they can, in essence, repeat it in their mind. It's like, I remember hearing this. And so some people have that auditory, and that works much better for them. And sometimes they'll repeat the words themselves if they have to read something, or if they're listening to, not if they're listening, but if they come across information, they may actually read aloud or repeat to reinforce that information. The people who like reading and writing, sometimes they need to take notes and get it into writing if they're hearing a presentation. If they're reading, they tend to do really well with that reading, and that sticks for them. Other people, you find that they glaze over if it's, if they're reading too much and too long because of the detail, it just doesn't stick as well for them. And those individuals also can help to cement the knowledge and the information by writing reports on things and summaries, and that helps. So kinesthetic, I think about Katie Ogawa, one of our former residents. She was learning how to do vasectomies, and she wanted to do some extra experience. And we already had a resident scheduled, but she came and she was just right there at the bedside. And every movement she was doing in real time, I could watch her and her hands move, and the gears whirring in her head. And so she was practicing all those steps manually for herself, even though she wasn't the one doing the procedure. But to cement that knowledge in her mind, she was going through all those steps. They use that with sports also, and they find that it's incredibly successful. That the people who practice, they find that they actually do better if they practice shooting free throws without the ball. And so there's that combination. Yes, you have to do it with the ball and the basket, but that mental practice of focusing on the steps, this is how I'm going to do it, is incredibly useful in terms of especially the kinesthetic learners, but also for other learners in developing that muscle memory. So especially with procedures on that. Practice is wonderful for adult learners. They really do benefit from doing the case scenarios, going through practice sessions, give them a case, let them work through it as a group, give feedback on how they're doing and their processing thing, and then interactive discussions at the end so that people can share their experiences. And also, as I mentioned, adult learners bring a lot to the table already. So other people can share how they would manage things, and that adds to the richness of the conversation and the learning. That group think process for adult learners is very important. Because people have had so many different experiences, they can bring those experiences and broaden the discussion, and we can all learn from what they've experienced in their lives as they share. And another thing that we find is that sometimes when you ask and you seek feedback from the group, any other options? What else might you have done? Or takeaways from a lesson. And sometimes you pick up on some things and you find that they picked up something that either you didn't intend to teach or is different than what you thought you were teaching. And it's like, that's really interesting. I'm glad you brought that up. That's not how I approach it, or that's not what I was intending. And what you find is then you can correct things in real time if you open things up and you get that feedback from the group and other people share their opinions. It's like, okay, well, when do you call it? I described it as patches. It's like, oh, I described it as macules. It's like, okay, well, let's take a look back. The patches were the big things and the macules were the small things. In the case we were looking at, they were big. So we should go with the patches as opposed to macules. So I find that opening it up always surprises me to find out the things that we can add to the learning process. As I mentioned previously, people tend to pigeonhole or use their mental filing cabinets to get information and then add in layers to what they already know. So I find that people do really well once they've got an initial scaffolding, and then you can build on the scaffolding. It can be useful to find out where people are at. So that does somebody already have a lot of experience in this field or maybe not much? And you can utilize that expertise. It's like, okay, this is a higher level learner or somebody with more experience in this topic. Why don't you give us a review on the topic and let's get everybody up to speed, and then you can launch from there. So before I go into precepting techniques, let me go ahead and open up and see if there are any questions that folks may have. Okay, I'm not hearing anybody jump in with any questions. Were any of you at the precepting session with the ShipRock group a few weeks ago? Okay, wonderful. So I won't be repeating too much stuff. Let's talk about some various precepting techniques. The 1 minute preceptor is probably the most well established in terms of precepting residents. We'll talk about, actually, I'm going to let you read this for a moment and then we'll go on. Because I know everybody who's made it this far knows how to read. Okay. Who likes the 1 minute preceptor? Or actually, let's pause. Who's teaching who where? I'm getting ahead of myself. I know we've got John who's teaching residents and students. Anybody else want to chime in?
So right now have medical students, but we'll be teaching residents hopefully in a couple of years.
Fantastic.
In Española.
We have several of my residents on, and they teach co-residents, junior residents, as well as students.
Excellent. Fantastic. So, and we've got probably then inpatient as well as outpatient. Okay, let's click on to the next slide. So the 1 minute preceptor. Does anybody want to volunteer and describe maybe a case that they've used the 1 minute preceptor on? I'll give it a moment. If nobody volunteers, then I'll jump in. Okay, so often, especially with medical students, they will present, they'll give you a long presentation because that's what they were trained to do in medical school, is to give the entire presentation. And then a lot of times they'll pause and then hoping that you'll jump in and give them the diagnosis and then the recommendations of what to do. The 1 minute preceptor reminds us, don't do that. It's like, ask them what it is. It's like, okay, well, what's your, so what do you think's going on? What's your diagnosis? And they say, well, I think they've got heart failure. It's like, okay, well, what are the hallmarks? What makes you think that they have heart failure? What are the hallmarks of heart failure? You know, it's like peripheral edema, or, you know, did they have any respiratory symptoms? It's like, or do they have any trouble laying down? So paroxysmal nocturnal dyspnea, or what's their physical exam in terms of their pulmonary exam? Do they have Rowell's on their pulmonary exam? Do they have an echocardiogram, or do they have lab tests? So probe into that if they didn't already present that, so that you know that they understand what the hallmarks are to get to that diagnosis. It's like, well, gee, the BNP, beta natriuretic brain natriuretic protein, is normal. Could it be some other reason that they've got swelling in their legs? They've got swelling in their hands and their face also. Could it be something else? Could it be nephrotic syndrome, or could it be cirrhosis with liver failure? Because not all leg swelling is congestive heart failure. So try and figure out what the differential diagnosis is, where they're at. And then in terms of teaching to general principles, it's like, okay, well, people with congestive heart failure need periodic echocardiograms to see where they're at. And I also ask them, it's like, so why do you think they have heart failure? It's like, okay, they've got heart failure, but there are different etiologies to heart failure. It's like having, you know, somebody, oh, their status post-hysterectomy. It's like, well, why did they have a hysterectomy? Because depending on why they had a hysterectomy, they may still need pap smears. So it's drill down that one layer so that they understand some of the general principles related to that case, so that they can incorporate that knowledge, so that next time they're going to ask about why a woman had a hysterectomy, so they know how to appropriately manage them. And then give them positive feedback for what they did. You did a great job of your physical examination in terms of heart failure. You told me about the Rowells and the peripheral edema and the cardiac exam. One of the things I do want you to pay attention to in the future is go ahead and do a chart review and see if they've had that echocardiogram in the last few years, so we know where we're at on that. So correct any mistakes that they've made, teach to the guidelines. So the activated demonstration model, this is really good for hands-on physical exam skills, and also can be used with counseling. This is where you allow the learner to actually present some of the details of what's going on. And then it's like, well, okay, I understand the patient has shoulder pain. Let's go see the patient. Let me watch you do your shoulder examination. Or if they're saying, I'm kind of rough on my shoulder examination, it's like, okay, well, I'll do the shoulder examination. Or it's like, I know you did a shoulder examination already. Let me show you how I do a quick and easy shoulder examination. So we'll go in together with the patient and I'll go through some of those maneuvers and I'll show them, okay, this is really good for supraspinatus testing. And I always like to feel the biceps tendon in addition to the acromioclavicular joints. And I can actually show them how to do the physical examination, sometimes even as they're telling me about the patient's symptoms, and we can do that together. So I'm either demonstrating or I'm having them do the examination, and then I can guide them and give them feedback. Sometimes we'll do examinations in tandem. So especially if you're working one-on-one with a learner and you have the opportunity to be in the room a lot, you can say, you know what? Hold off on doing the general physical examination. Just go ahead and start with the history, and then we'll go in together and we'll examine them together. Because one of the things we want to know, especially early on in the learner's experience, is do they know where to put the stethoscope for a heart exam? Do they know how to do a pulmonary exam? Are they going underneath the shirt to listen to the lungs? What are they doing in terms of like a hernia exam? That's one of those ones when I see people, even some of the upper level residents doing a hernia exam, we just don't do as many of those as we used to. And sometimes they're not really smooth at it. It's like, okay, I'm glad we went here together. Let me go ahead and show you another way of doing the hernia exam, or another way of doing some of these physical exam techniques. And doing that together actually takes less time in terms of the clinic flow, and also gives you that perspective. You can assess and see where your learner is at with their physical exam skills. Okay, so I'm so glad, John, that you've got some residents and maybe some students there who are joining with us today. Sometimes they realize or learn about precepting techniques, and it's like, oh, those are those Jedi techniques that you've been using on us the past year. And it's actually kind of nice if they learn about the 1-minute preceptor and they learn the types of things that we expect, they'll actually adjust their presentations and they'll go, it's like, okay, this is my assessment, this is my differential diagnosis, this is my plan. And you can just sit back, it's like, that's great. You're hitting all of the things and all those milestones that we would like you to do. The other Jedi tricks that we do in the patient's room is, if I get the sense, so I'll sometimes like, do you want to do the talk about using the topical 5-fluorouracil for skin cancers, or should I? And sometimes the residents, it's like, yeah, I know that one. I'm going to go ahead and give it. So they'll talk to the patient and I can observe that and make sure everything's good. Or if they don't know that, then I'll give the talk to the patient. And sometimes I'll ask the resident, sometimes if I know that they don't know how to do that, I will give the counseling to the patient and I will be teaching the patient, but the resident is there and they're absorbing that information so that next time they can do that. Sometimes I'll flip the table. Sometimes it's more comfortable. It's like, and I'll actually teach to the resident for the patient's benefit. And the patients love it. They love having us in the room and talking about their care, because if we're not in the room talking about their care, they think we're checking email or seeing somebody else. So as the case may be, sometimes teach to one and the other one learns, or vice versa. Okay, so often we have residents who do procedures, or students who are doing procedures, and we will go in with them because Medicare requires that we supervise all procedures, and also we want to assist them as the residents get further along in their training process. I jokingly tell them, it's like, oh, I'm just here to be a good assistant, to make life easier for you. But sometimes you get a sense, that they see something that they're a little surprised about, or things are a little bit different than they anticipated, or there's some deficits in their knowledge base. And you can actually guide what they're doing. So let's say it's an early learner in terms of a pelvic examination. It's like, okay, you're going to feel Dr. Smith touching the inside of your thigh. Next, you're going to be feeling Dr. Smith touch the speculum to the posterior aspect of the vagina. You're going to feel some pressure as she inserts the speculum. You're going to feel some more pressure now as she opens it up. And next, we're going to be doing this. So you can actually tell the patient what to expect, and in essence, tell the learner what they need to do. It's like, okay, next we're going to be grabbing a hold of the cervix with a tenaculum. You're going to feel a big pinch with that. We're going to pull some gentle pressure on that so we can do the uterine sound. So sometimes the resident or the learner may not know all of those steps, or you sometimes find yourself having to reinforce those steps. So you can do that. And with maintaining the respect for the learner as the patient's PCP or involved in their care, without letting the patient know that the person is getting help, you're just telegraphing it to the patient, and then the learner can pick up on those cues so that they can know what to do. Some people will build in a code word or an action in terms of, if you need the learner to pause or to stop, then you'll build something in. It's like, oh, can I show you a different way of doing that? That you might find helpful for, X, Y, or Z. It's like, oh, can I hold that for a second for you? Let me free your hands up. It's like, a lot of times I like to keep the instruments in the learner's hands. It's like, and some people are better at receiving that feedback than others. Some people stiffen up when you grab their hand. It's like, okay, if I reach out, usually I'm not trying to take the instrument. So keep your hands on the instrument. Let me guide you with my hand on your hand, checking beforehand. Some people are real sensitive. It's like, may I go ahead and touch your hand during the procedure if I think you need help, so that they're not afraid, so that they're not surprised. And it's like, then relax your hand, go with it. Let me go ahead and help you on that. Because some people, they just stiffen up for some, well, it's just different styles. Okay, orienting the learner. How many of you, first day when you're with a learner, give an actual orientation? I see John raising or nodding his head, yes. Some of the other people aren't sharing screens, so I can't tell. So one of the things that you'll see in major corporations that are very successful, they invest a lot of time in terms of orientation, because they know that they'll get their investment back. If you let people know the things they need to know right up front, they'll be more successful. So when I have somebody who comes to work in my clinic, they've not been in my clinic, I'll give them a tour of the clinic. I'll let them know where the charts are going to be. I'll let them know, hopefully they already showed up on time, but what times, so I'll actually send, I send orientation materials ahead of time via email, and then I do the stuff that we need to at the time. It's like, I'm one of those docs that likes to do presenting in the presence of the patient. We'll talk about that later. So don't do the whole physical examination. Go in, get the initial history, and then we're going to go back in together. Let them know you're working with me, ask their permission, and that I'll be coming in later so that they will be able to see me, because a lot of the patients scheduled with me as opposed to the resident. If it's in the resident clinic, it's different. For the resident clinic, they're going to be giving this information to the student so that the resident can tell the student how they like to work in terms of what they want to do. It's like, I want you to get a full review of systems, or This is a quick follow-up visit. Don't drill down on everything. This is somebody who we need to make sure their blood pressure is controlled. They're not having any side effects from their medicine. So focus on their medication compliance, any troubles or problems that they're having with the new medicine, and then we see if their blood pressure is controlled. So if you set up those expectations, you'll be more efficient so that the student doesn't go in with a quick follow-up visit and do a complete history and physical examination when it's not needed. Also talk about limitations. It's like, you know what, if this is going to be a sensitive examination, don't grab the medical assistant and do the sensitive exam with them, and then I have to repeat it. Let's just do that together. So you can let them know about expectations, responsibilities. I want you to write some little handwritten notes on this little face sheet, because if you do that, it helps me and I can write the note. If you don't give me any of those little tips on that, you're going to have to write the note, so or let them know. It's like, today you're writing all the notes, or today you're not writing any notes, but I want you to do a learning issue. So you can let them know how to organize their time, and when they can ask questions. It's like, yeah, it's fine to ask questions in the room. Or sometimes it's like, no, I don't like, some people don't like having questions in the room. It's like, wait till afterwards. Do I need to see every patient? It's like, no, don't see every patient. Go see this one, come out, wait for me, because I'll be seeing somebody else while you're seeing that patient. Okay, so the SNAPS theoretically is a more advanced model for people who are upper level learners. It's more learner driven. They're supposed to come to you starting with some people say starting at the end. Summarize the H&P, or that summary statement that often people are taught to do. So instead of doing the full history, it's like, okay, this is a 64-year-old patient who comes in for follow-up diabetes, and their labs are all at goal, and I'd like to plan for their future care and their health maintenance. Narrow down the differential diagnosis. Let's say we were talking about, let's transition to 65-year-old who was recently started on a statin, and they come in and they've got elevated liver function tests. It's like, okay, well, so they should be thinking, it's like, are the liver function enzymes elevated because of the statin? Is it because they drink 6 drinks of alcohol a day? Is it because they recently were exposed to viral hepatitis, or there's mononucleosis in the family? So have them work through the differential diagnosis, narrow it down, and then you can work through them with that to give them feedback on their differential diagnosis. And then you can ask about any things that they didn't think about. It's like, they come in, it's like, oh, I need to do a big hepatitis workup. It's like, oh, remember, they just started on a statin. Do you think it could be the statin that's causing their elevated liver function tests? And then you plan the management for that. And then you may select an issue for self-directed learning. It's like, well, are there different statins that tend to bump the enzymes more than others? Should we be looking at a different enzyme or a different statin? What's considered acceptable? If it's only twice normal limit, can we go ahead and treat? Is that considered acceptable, or do we need to change that? So you can look towards a learning issue, either for their benefit, or if you're a community preceptor, you can have the learner look something up for mutual benefit. It's like, I forget. Are we allowed 2 times normal, or are we allowed 3 times normal, or was it 1.5 times normal? Why don't you look that up and get back with me tomorrow, and then we can adjust our management. So just for your reference, this is a more detailed chart in terms of the SNAPS model, as well as some examples, but we already went through an example. Okay, I'm going to guess not many of you have heard about the GRIPE model. This was presented at the Society of Teachers of Family Medicine a while ago, and it's good for chronic care. And this was the most fun name that Dean was able to come up for this. So this is the type. This model is good when the resident comes in or a learner comes in. It's like, Javier is here for his refills. So I refilled his medicines. It's like, okay, that's a great start. What conditions are we treating with his medicines? Oh, he's got diabetes and he's got hypertension. He's got hyperlipidemia. It's like, okay, well, are they at goal? what's their A1C? Are they a goal for their diabetes? Are they a goal for their hypertension? What are the guidelines for blood pressure control in this individual? And sometimes people, it's like, he was asymptomatic. I just gave him his refills. It's like, okay, but it's been a year since he's been in. Where are we at health maintenance? Do they have any pain issues? When this was presented, pain was, the fifth vital sign was really popular at the time. So do they have any pain issues, or is there any palliative care needs, was the P. And then effective feedback. For all these techniques, we do want to give feedback, coaching, guidance to the patient, to the learner. And remember, learners don't always recognize that when you're giving feedback, that you are giving feedback. So sometimes you can label that. It's like, I'm going to give you some feedback. It's like, I think you did great with your examination. My feedback for you today is that we want to look to their health maintenance issues when this is somebody who hasn't been in for a year. Okay, so let's take a step back and get to the big picture. When you're the preceptor, you've got 4 residents in a big, busy afternoon or morning in the clinic. So as a preceptor, being an active preceptor, you want to serve the residents. I mean, we're serving the residents. We're in, the reason why we went in this is to teach. Otherwise, it'd be a lot easier in private practice without the teaching, but we love teaching. We love helping the residents be successful, or the other learners be successful. So we want to make the precepting experience the best it can be for the residents in their delivery of patient care. So we like to be proximate in the same room, where the residents typically cluster, as opposed to, oh, I'll be in my office, come get me if you need me. It's like, we want to be present physically, we want to be present mentally, and make sure that they have our full attention when they need our full attention. Of course, yes, if there's all the residents are off in the rooms, please do your inbox stuff. Get those things done and be productive when they don't need you. But when they need you, put it down, make eye contact, focus on what they need. Some people like to take notes in terms of listening to the residents. You make little check boxes, and it's kind of fun because you make little check boxes and you can give them feedback. It's like, hey, you did really great. I made feed boxes and you hit all of the things that I wanted you to hit in terms of this patient with diabetes or their heart failure. So the preceptor can keep tabs on what's going on. If you've got 3 or 4 residents, you try to keep tabs. It's like, okay, I haven't seen this one in 2 hours. What's up? Or this one's over here. It's like, hey, how are things going? It's like, well, I've had 3 no-shows. It's like, okay, well, let me check with the charge or the MA and see, because this person seems, we find out it's like, Dr. Jones is 4 patients deep now. We don't even have rooms to put them in. It's like, oh, you had no-shows. Do you think you'd be able to, let's take a look at the schedule. Do you think you'd be able to see this one who's an acute care visit that got added on? Probably not the chronic follow-up that the resident already knows, but maybe there was a double book and then you've got somebody else who's got an open schedule. So you want to help with flow. And sometimes it's like, oh, they need a prescription. We need our case manager to get involved. And you find that the resident's busy and they already know how to do that. But it's like, okay, let me take it over to the case manager and help them with their forms on that. Or let me put that lab in, or that x-ray order in, or that consultation in, if the resident's busy and they need that type of assistance because they're feeling pressured because they're a couple patients behind. If they don't need that assistance, then focus in on the other folks who may need that assistance. In terms of precepting ratio, Medicare allows us a 1-to-4, 1 faculty per 4 residents. And if you only have 1 resident, you're actually allowed to work at half speed. So you could schedule some of your own residents. Not too many programs that I've seen are doing that unless they're routinely doing a 1-to-1 ratio on that. But you can see a few of your own patients if you only have the 1 resident, so that you're available enough for that. At the University of New Mexico, the target goal is 1-to-3. Some people, some of the faculty feel a little stressed with 4 residents, and you're more available if there are only 3 residents, gives you a little bit more flexibility. And also if there are 2 faculty, let's say you've got 5 or 6 or 7 or 8 residents, and sometimes you have to duck into a room for a procedure or for a level 4 or 5 visit, it's nice to have a second preceptor who can be there present for when a resident needs. If I have to be in a room and I'm the only one there, sometimes I'll take a little piece of paper and I'll, fold it and put it over the monitor screen. It's like procedure in room 4, so that the residents know where I'm at. And if they don't need precepting right then, they'll just continue with their workflow and then they'll present later. First choice, South Valley, if they've got 4 or more residents, they like to have 2 preceptors. And sometimes you've got the opportunity, depending on your clinic's setup, is you can sometimes have somebody who's not really precepting, but they're in their office doing admin work. And you could say, you know what, if we get too tied up, you can always check with Dr. Jones in the other room if you need to. So this does require some situational awareness, and it can be nice to start the morning touching base with the residents, like, okay, do you have any wellness patients or procedures so that I know who I need to see and when? We can give a heads up to the other residents. It's like, okay, at 10 o'clock, we're going to be doing an IUD removal, or we're going to do an Nexplanon removal. And you know how those, sometimes they go really quick, but sometimes they take a bit of time. So let folks know where you might be on that, and also to be aware of, oh, you've got somebody for a knee injection. It's like, okay, well, what approach do you like for the knee injection? Have you done many of these before, so that you've got a sense for what the resident needs in terms of assistance? Like, why don't I show you a video of how to do a shoulder injection, since they're on your schedule and you said you've only done one and it was in medical school. So you can prep them, and once it gets to be time to do the procedure, then you're in better shape for that. As I mentioned before, if you're doing any of that side work, just drop it immediately, catch up with it later, so that the residents know that you're focused and you're invested in them. Same thing with the patients, you're focused on them, you're invested in their care, and people really do appreciate that personal touch when they know that you're really invested in them. So we already talked about folks who sometimes are getting behind or they've got no shows. And it's good to know chatting and establishing and maintaining relationships is extremely important, and is one of those lifelong connections that you can develop. You just need to make sure they've got time for it. And you don't want to bring in too many stories if the residents have a lot of patients that they need to see. So sometimes I'll touch base. Do you have time for a story? It's like, no, not now. Like, okay, maybe later, or maybe not at all. So you just situational awareness. Feedback that we get from the residents is they like for us to be able to help them anticipate the next steps. It's like, okay, we ordered these labs. It's like, okay, now what happens if they come back abnormal? What happens if you send that patient for a chronic cough for an X-ray and it comes back as a mass? It's like, oh, okay, I don't know, is it MRI, is it a CT, or is it pulmonary consultation? So you can, or what happens if this second antihypertensive that you start today doesn't work? Do they need to come in, or can they just be doing a blood pressure at home and then contact you with results? And what might be the third agent that we would add on for them, so that they're looking to the future, and then they can get the information they need. There was a while ago, I was teaching, I was at a community preceptor that's like, oh, they've got a lump. Let's do a, it was a breast lump. Let's do a fine needle biopsy. And then the report came back, and then they had to ask, okay, now what do I do with the report? And the people there said, oh, we don't do fine needle biopsies. We refer those all to the surgeons. What did you do here in clinic? And it's like, it was a mess. So it's like, what to do? It's like, okay, these are the expected results on this biopsy, or you can reach out to me in case the other preceptors don't know how to manage those things. So it's good to be thinking about what the next steps are. Let's see what else we've got on this screen here. So providing new or teaching points. Sometimes when they're busy, I'll say, you know what, I'll look that up for you and I'll get back with you. And so I might look up some information, whether I use UpToDate or other resources, and I'll drop them an email. It's like, or it's like, do you like printed information or written? I might look up something in the medical letter. It's like they did a review on antidepressants lately. Let me go ahead and get that for you while they're seeing the next patient, because it'll take me a little bit of time to pull that up. And so I might give them the printed if they like, if they're a visual learner that likes paper, I'll give it to them in paper. If they like the electronic, I'll email it to them. Okay. Other things that the residents appreciate is if it's a level 4 or 5 or wellness that the faculty have to go in per protocol to see. It's like the residents don't want to impose, and they take away different impressions from different preceptors. And some of the preceptors is like, oh, they're always so busy. I never do any level 4 or 5 visits because the preceptor is so busy, doesn't want to come in the room. If that's the way you want it, that's the way it can be. But if you want the extra billings, the residents are working hard and doing fantastic work. It's like, let me know if it's a level 4 or 5 visit. We can actually go in the room. You can tell me about it in the room if I know I'm going to have to be in the room anyway, and that actually can go faster. Oh, so wellness for a kiddo. Is there anything you wanted me to focus in on the physical examination? Are they done? Do you need to see them after I double check on the examination and they get their shots and their follow-up visits? Like, no, I'm off to see the next patient. If you can just let them know that they can head on out after they've got their follow-up visit, then that can streamline things for the resident, and there's no downside effect from them not going in. And sometimes if it's a senior resident and they know what they're doing, it's like, hey, I know you saw Dr. Andazola today. Did Dr. Andazola take care of everything that you needed today? So, oh yes, I love seeing Dr. Andazola. He's been my doctor for the last 2 years. And he's just wonderful. He's so kind and attentive and pays attention to all my needs. It's like, oh, great. I'm just so happy to hear that. And we'll look forward to seeing you again in the future. So you just touch base, because if you walk in the room, you generally, there's from the door, it's like sick, and they need to come in the hospital, or not sick. And some people it's just, I just need to get in there to make sure everything is good, because the residents already told me the information I need, but I need to add that value for Medicare. Okay, some of the things we want to avoid. If a patient comes in for an acute care visit, and we want to make sure that, yes, their acute care needs are taken care of, but we also, if there's not enough time, I know some people say, oh, if they're in the emergency room, you should check their immunization status. If they ever step foot in your office, you should check their immunization status and their wellness. It's like, if we did, there are people who've said that if we did everything we're supposed to do for every patient, it would take 23 hours a day to do a standard load of patients. So we need to be careful. Somebody gets double booked, there's a quick, add-on acute care visit. That's not the time to drill down into health maintenance issues. It's like, oh, I noticed they haven't been in a couple years. Let's have them come back and spend the time that we need to give them a valuable annual examination on health maintenance for that. But don't start drilling into everything when it was just supposed to be a time-limited visit. So the residents like us to be aware of that. And in terms of teaching, they love for us to teach. Keep it focused, little 30-second teaching spots, something relevant to the care that they're providing, and then move on. You don't have to teach about everything every time. Okay, let's see if we've covered all of these things. I think we have covered all these things here. In terms of things to avoid, I think we covered the things to avoid. Okay. So as you know, not all the learners are the same. We have learners that are medical students. We have learners that are fresh interns coming up in a month. We have learners that are right now thinking about their future practice and are ready to head out the door. There's a huge range of the skill sets. And what I have found in the past is I'll have a third-year resident who comes in and they give me this whole long story about the past medical history, and then they said, and they've got, they come in for a 2-day history of cough, rhinorrhea with no fevers. It's like, hold on a second. Are you telling me they've got a cold? It's like, yeah. It's like, do you know how to take care of a cold? It's like, yeah. It's like, because you're graduating next month. It's like, okay, next time for me, and different preceptors have different comfort. For me, just tell me they've got a cold. and that they've got a viral syndrome, you're planning symptomatic care. And if you've got any questions, that's all I need to document it. But some of the preceptors like to go from A to B to C to E, D to E. Some of the preceptors are good with, oh, heart failure. Okay, are they controlled? You know, like some people are willing to go from A to E. And you choose it based on your experience with that learner and the learner's experience in terms of, hey, they've got this. Like I said, they're graduating. It's like, just give me you've got 5 charts in front of you. I'm assuming all these patients are gone and that you thought that they were stable and you covered everything. You don't need to go telling me huge, big stories. Just tell me what I need for the documentation purposes. But I'm also paying attention if something comes up that I catch on to that's like, okay, there's something a little bit funny on that. It's like, gosh, so these multiple seemingly unrelated neurologic symptoms, a weakness in hand, a visual problem. Did you think about multiple sclerosis? It's like, oh, okay, maybe we do need to contact that patient, you know, for pick up on a little something that that the resident may have not considered. But most of the time the residents are on board and the patients are already gone. It's like, they're already gone. How much am I going to change things? So that recognition. So one of the things that I realized was it's nice to know what frame of mind the resident is in so that I can best serve the needs of the resident or other learner. We talked about the different levels and different needs. So of course, necessity is the mother of invention. And we had an afternoon where I think there were 7 residents and the other preceptor was not there. So it was, okay, how am I going to take care of all of these residents and all of these patients and what they needed because there was no backup. And what I realized and thought about is Tucanos. Okay, so if any of you have been to the Tucanos Brazilian Grill, they've got these table markers. And if you turn it green side up, that means you want them to come by because they pull the food, roasted meats, vegetables, fruits, or whatever off the grill, and they come around and the servers walk around. It's like, oh, would you like some of this filet, or would you like some of this sausage or this chicken? And if you turn the table marker to red, they know that you want to pause. You're either full or you're enjoying your company. So I converted that to the Tucanos method of precepting, which I consider a learner-driven method. And so when the resident comes to me, they just take I actually have one here because I love toys, but they take the table marker. And so they may turn it to green. So green side up, sorry, the screen blurs out, but green side up, it's like, I want information. I'm not sure what's going on. I need help. So when they turn it green, and it takes all of half a second to do, then I know that I need to really focus in on what they're trying to get out of this and how to help the patient. If they turn it to red, it's like, this is the cold. It's like, they got a cold. It's like, okay, we're good. This is follow-up hypertension. Their blood pressure is now 132/66. And we did all of their health maintenance last time. So we're good to go. It's like, fantastic. You know, that's even less than a 1-minute preceptor. And we're set on that. Sometimes they'll knock it over sideways like, I'm not sure. Let's talk about it and I might need something. Or or some of these third years on their way out the door. It's like, I know how to manage hypertension, but let me go through some of the finer points. It's like, okay, so at what point do you like to do, check renal arteries? Is it after 2 drugs, 3 drugs? When do you get renal involved? Some of the finer points. You may not have a Tucanos table marker. The first time I did this, I didn't either. And there was a cup with paper clips and I just tossed out the paper clips and it's like, okay, if I turn it up, then I know it's open. You want me to fill up your cup. And if you tip it over, then I know you don't need anything and then we can move on. So that was how it started on that very first day. But it's been wonderful for me, at least. Things that are great for me may not be great for you. I do realize that you're all adult learners and you might have different needs and different perspectives. This is some of the feedback that the residents have given. They said it cut down on time they needed to precept. Their efficiency went up. They actually gave them more confidence. It's like that they could drive the scenario and based on what their needs were. So they felt more confident that they were managing the care, and also to develop that trust. It's like, okay, the middle of the night, do they need to call you with every admission? It's like, okay, or do we let them run without the training wheels and then they manage stuff and only call us if there's problems? So this is similar to that. It's like, run with it and let me know how I can help you. Some people call this teaching in the presence of the patient, and it's like doing bedside rounds when you're in the hospital. So why would I ever want to do this? They've done some studies. There are actually 4 RCTs, and I've got the references later for you, looking at this. And faculty tend to love this technique in terms of presenting in the presence of the patient. And that means you're there with the patient. The other way of precepting is CRS, or conference room staffing, where the resident comes out, they talk with the preceptor, and then the resident goes back in as needed, or the faculty goes back in as needed. But presenting in the presence of the patient is the resident comes out, or the learner comes out, grabs the faculty, and they go in the room. And students, if there are some students there in Las Cruces, you can grab your resident and pull your resident in and talk in front of the patient. So faculty are very comfortable usually with this and feel that they're able to teach, that the patient involvement was good, and that it actually helped with the flow of things. So the residents thought it was, a lot of the times they thought it was a wash. It didn't really decrease their autonomy. Every once in a while you'll get a resident, it's like, well, I don't want the patient to know that there's a faculty in the next room who's actually supervising or responsible for the care. I want them just to think about me as their PCP and that I'm the only one. So occasionally you'll have some people question them that state that it feels like they don't have as much autonomy if they have to bring a preceptor in to discuss in front of the patient. The residents, in terms of asking questions, they found that that sometimes the learners were a little bit less likely to ask questions in front of the patients because they didn't want to be vulnerable in terms of not knowing some information. On the converse, preceptors tended not to do any of the, or tended to do less of what some people call pimping, in terms of the negative way of, instead of Socratic teaching, which is a good thing, drilling down is a bad thing when you drill down too far. So biggest thing also for the learners is they have to choose their words carefully. It's like, just say Jane. Don't say that they're a 57-year-old female. It's Jane's 57, more personable type of thing. Try to avoid some of the medical jargon so that the patients know what you're talking about. So a lot of people are worried this is going to take extra time, and they've actually done time studies, and it actually takes less time. So it ends up taking less time for the preceptor, on average 2.3 minutes less faculty time per encounter. So if you did 20 encounters with a resident doing this technique, that's 40 minutes you could save during the course of your work with the learners. And you ended up spending, there is more physician, more provider time with the patient. So in an era where people say, oh, my doctor never spends enough time with me, that's a frequent complaint. It's like, you're actually spending more time with the patient. All of that time that would have been spent in the conference room, you're spending with the patient. And the nice thing is that the patients actually perceive that they overestimate. They estimate that the provider spent more time than they actually did. It's like, that's a win-win situation. I love win-win situations. So the patients really like this technique also. They love having us in the room talking about their care because they get to see how we think and process, consider those differential diagnoses, and they get to have that information reinforced and get to see, it's like, wow, my resident physician really knows their stuff. This faculty physician is really good at helping the resident, and I get the benefit of both of those minds because, as all of you know, sometimes we bounce things off of each other and we learn from each other and bring in additional information. So this is just a little bit of a review that we talked about these things, I believe covered all of those things before. Keep in mind, is the learner struggling, how much extra attention they might need during their process, keeping in mind the level of the learner, what's the expected level of their abilities at this point. Okay. And in terms of, these are just some resources. I'll let you read these. These are some of my favorite resources for having, 30-second or 5-minute teaching points that I fall back on. Or let's say we're walking from one hospital front on the inpatient side, we're going from one hospital tower to the next tower. I'll pull out it's like, okay, well, tell me, this patient had a low potassium or an elevated calcium. Let's talk about hyperkalemia or hypokalemia, or let's talk about hypercalcemia as we're walking and heading to our next destination. So have those. It's like, okay, well, what cancers metastasize to bone? Have some of those little pearls in your pocket so that when you've got downtime or you're going for a long walk to see the next patient on the next floor, instead of talking about that individual patient in the hallway or in the stairwell, we don't want to violate HIPAA, have those little teaching pearls so that you can teach. So I'm just going to click through to the end. These are the references for if you are the type of person that likes to drill down on references. And then I want to thank you for joining us today. And we've got 2 minutes. If there are any last discussion points that anybody wants to raise, or your comments, or share a quick share of some of your favorite techniques that we may not have covered today.
Dan, thank you a lot. I learned some good stuff. So thanks a bunch with the teaching. For me, I think I just really wanted to talk that some of the stuff I'm taking away from here. And one of the big ones was really learning how to precept in the patient's rooms 4 and 5 visits. And I suppose you could use the PIP and TIP model to do that, save some time and be right there with the patient. I thought that was brilliant. I loved that because we missed that opportunity quite a bit. So I wrote that down. I've been taking some notes. And the other thing that you said was you really briefly mentioned about feedback. And a lot of times we make teaching explicit. I'm going to teach you now. We're talking about teaching, but you mentioned about making feedback explicit. And I really thought that was a very valuable thing. I haven't used snaps. I wrote that down, but for me, my 2 big walkaways is teaching in the room level 4s and 5s, and really making that feedback explicit. So thanks very much. I'm going to start using those. I'll let you know how they pan out.
Fantastic, John. I really appreciate that feedback. We are at our time. Thank you, everyone, so much. Thank you, Nicole. Thank you, Mario. Appreciate you putting this together and recording this for us, and hope everybody has a wonderful afternoon.
Thank you so much, Dr. Stulberg. Thank you, everybody. We have a post-webinar survey in the chat if you'd like to fill it out, and then links to register for our upcoming didactic series. I'm here if you need me. Feel free to send an email. Thanks, everyone.